Good afternoon. I'm Jeff Englander. I am your host. I am the founder and principal of Healthcare Strategy Bullpen. It's my pleasure to welcome you to Diagnosing Healthtech. Our co-host this afternoon is Carolyn Brinkerhoff. Carolyn, good morning, or good afternoon, rather.
Hey, Jeff. Good afternoon to you. Hi, I'm the Director of Solutions Engineering at Redox, and we're so excited to welcome our guest today. Jeff, I'll let you introduce Jennie.
Thank you. And our guest today is Jennie Shulkin. Jennie is the co-founder and CEO of Override. Override is a non-opioid chronic pain company. Jennie is, as I said, the co-founder and CEO. She is a former attorney. She also worked in the Manhattan District Attorney's Office as an assistant DA. She is a graduate of the University of Pennsylvania and Harvard Law School. And so welcome, Jennie.
Well, thanks so much for having me, Jeff and Carolyn.
So, Jennie, can you talk to us a little bit first, give us an introduction into Override and kind of what your approach is, and then we'll kind of dig into chronic pain a little bit more.
Absolutely. Override is virtual interdisciplinary pain management for people with chronic pain. So that's people who have had pain in any part of their body for 3 months or longer. And at a very basic level, what we do is we have care teams of pain doctors, chronic pain trained physical therapists, pain psychologists, and certified pain coaches. All of them work individually with the patient, and they also work together as a team. So a couple things that we're doing differently from everybody else and from the traditional pain medicine. First of all, it's virtual, so you can have comprehensive care if that's what you need without disrupting your entire life. Second, we have chronic pain specialists, which are extremely difficult to find. Third, we use a team-based approach to care, which is very, very rare. And I could probably go on for a while, but it's a pretty special program that we have, and we're getting the outcomes to prove it.
So, you talk a little bit about, and we'll ask you on for a sec, in terms of the team-based approach to care and how that differs from kind of the disjointed, fragmented approach that a lot of people see. Just talk a little bit more, what led you to do that?
So this isn't unique to chronic pain. It happens across many chronic conditions. But let's just take someone with chronic pain. Let's say they are having a surgery. They also have a primary care doctor. They have maybe a pain medicine doctor. They maybe have a physical therapist, and perhaps they even have a behavioral health worker, like a social worker, a psychologist. I would bet that in 99 out of 100 cases, those providers are not all communicating with each other, if any of them are communicating at all. And the result is often a patient seeking second opinions and different treatment plans from different providers and being pretty confused and spinning their wheels. So we see a lot of patients who don't really know which treatment path to take as a result of differing and contradictory advice from a very siloed system of medical providers who are not working together.
Now, does this manifest itself also in, because chronic pain was often prior or even still with the opioid crisis dealt with through pharmaceuticals? Does this lead to a large number of patients getting on a number of different medications for the pain, sometimes that may not be conflicting, but may not be working together in the best way?
So I'm just going to take you back in time a little bit before the opioid epidemic. If we go back to the 1980s, people were actually getting chronic pain management treatment through interdisciplinary team care, kind of like what we're doing now at Override. And it was effective without opioids, but it was expensive, a lot more expensive than those little pills. So eventually, once doctors and people in the pain management industry signed on to opioids, the interdisciplinary rehab centers closed for the most part, and they were replaced with opioids. Now, fast forward to today, and we've, criminalized essentially opioids and determined that we need to get all patients off them at all costs, which is a very controversial opinion in general. But so as we're doing that, we're finding that we need to give patients non-opioid alternatives, and there aren't too many of them out there, which is another reason why what we do at Override is very special. I'm not sure if that totally answered your question, though.
No, I think it did. Thank you. So let Carolyn get in here. Carolyn, go ahead.
You mentioned that like this existed in the 80s and was highly costly. So have you adopted any strategies from the 80s that you now employ today in a virtual space? Like what strategies do you use to foster that kind of effective communication and collaboration across a whole care team that's required?
Well, one of the really interesting things about Override is that we are basically the only company in the world doing this. There may be one or two other programs here or there, but it is not a saturated space because it's a very difficult model operationally and yes, financially. As a fairly new company, we've only had our doors open for patient care for our full licensed provider approach for a little over a year. We have to try to fit into the existing healthcare system, at least to start. To change anything, you have to start where everyone else is. And so that means the reimbursement system, using that for fee-for-service appointments, which doesn't compensate us for a lot of the special parts of our model. We have an entire mobile app with an in-house pain neuroscience education curriculum that we've built and is a big part of patients' recovery and their experience in the program. We let them message their providers any day, every day. We have a whole meditations library. All of this stuff is stuff that the current medical system is not reimbursing for. So to a certain extent, yes, we are using a lot of what was in the 80s, but we've had to modernize it. And we also have to find a way to move the needle of where the existing reimbursement system is in traditional pain medicine to where we need it to go to get the recognition for this type of model that we feel it deserves.
How are you approaching that? Just generally like integrating this virtual care experience into those existing healthcare systems and workflows? Like what is the first thing that you want to tackle when it comes to reimbursement or just making it more the status quo?
Well, so we're not totally integrating with other systems of care. This is pretty foreign to places that are operating in the way that they've been operating for decades. We do like to work with providers, with health plans. We ask them for referrals. Typically to a provider, we'd say, these chronic pain patients are some of your most difficult, time-consuming, frustrating patients. The patients who are going to the ER for chronic pain issues and then calling you at 9 p.m. and saying they need a refill or they're having a problem. So let us give them more comprehensive, more specialized care, be wraparound support for you. And the patient will still keep coming to you for all of their in-person needs. And maybe that is an opioid refill, or maybe it's an injection or something like that. So we are working within the existing system and we're working with health plans, generally in a fee-for-service way, just like your doctor would or my doctor would. But as we gain exposure and recognition and more people start to understand that there's a more effective way of treating these patients, we intend for the system to change with us.
So Jennie, I know you've got a contract with Meritus, I believe, and you've got one with a national payer who hasn't been identified yet. Can you give us a sense of, you alluded to a little bit, what types of things you're working with them and how you might see as you grow that moving from, say, fee-for-service into maybe a more value-based care model where you might be able to include some more of those wraparound services or get paid more completely for them?
The idea essentially is that we start it with a limited pilot often, or some sort of limited partnership between us where we both are studying the clinical and financial outcomes together. And then at the end of a set period of time or a set number of patients evaluated, we sit down at the table and say what might be more fair, a better way for us to contract and serve your patient or member population.
And are you targeting a specific part at the initial phase of, say, the pilot or the contract of their population, a particular subset of people with chronic pain?
Well, what's interesting is every plan and every health system has different priorities. So right now we're talking about contracting with one health plan whose priority is really opioid use and getting their members off opioids or to use opioids safer. And so they'll be taking our criteria for chronic pain patients, if that's a pool this big, and then they'll narrow it based on opioid use. Another plan is narrowing that pool of chronic pain members and is narrowing it based on ER visits because they're targeting the really high spend patients or members. So it really depends on the priority, but for the most part, we are supplying a wide range of conditions that they can work from within their population. And maybe that is a point worth double clicking on. I often get the question or the implication that chronic pain is musculoskeletal pain.
Mm-hmm.
And what I like to say is that chronic pain is so much bigger than musculoskeletal pain. If musculoskeletal pain is this, chronic pain is this. There are women's health issues, there are GI issues, there are migraines, there's, conditions like Lyme disease or fibromyalgia or rheumatoid arthritis. And when those patients walk into a traditional physical therapy center, let's say, or one of the virtual PT giants that we're all following, they're often quite literally sent away and told that they can't be helped. And so where are they supposed to go?
Interesting. Carolyn, did you have another question?
Yeah. So I think this leads great into my next question, just around where are they supposed to go from that? Like from that, Jennie, what are the key benefits of virtual care for these kinds of patients with chronic conditions compared to that the traditional in-person care?
Well, I sometimes refer to this patient population as the forgotten patient. These are the patients who, after they have failed traditional treatment like physical therapy or pills or surgeries and injections, they're often told by their doctors that they'll just have to live with this, or they're out of options, or sometimes even, and especially women get this one, that the pain's probably all in your head. And it's a really heartbreaking experience that I know personally, to just feel like there's nothing left for you to do. And that's a large reason why we created Override, because we don't believe that that's the case. But what we do believe is that complex patients with stubborn chronic pain in particular need a comprehensive experience that the traditional pain medicine system isn't designed to provide. So, I mean, if we do have patients who really are on a spectrum of very moderate pain to very severe pain. And so a patient with moderate pain may have a very reasonable schedule and number of appointments throughout the month. But on the other end of the spectrum, a severe patient could have up to 7 appointments a month between their various care team providers, which, is at most 2 appointments a week. It's not crazy, especially when it's all virtual. You don't have to get in your car and drive somewhere. You don't have to sit in a waiting room. And a lot of these patients were doing that amount of appointments anyway, but did have to totally disrupt their lives, their jobs, their families to attend somewhere in person. So, I mean, the way that I see it, the benefit of virtual care, especially in a comprehensive program, is that you get the amount of care that you may need, however much that is, and even if it's a lot, but it doesn't actually disrupt your life in nearly the same way as if you had to attend in person.
What has been the feedback from the providers that you work with, from the specialists that you work with? They must have access to a whole other pool of patients, right? And like be able to treat more, understand the condition better. Like, are you getting any interesting insights out of them?
Absolutely. First of all, they really appreciate the team-based approach because working with chronic pain patients is extremely difficult. Every patient has a really sad story. And especially if you're spending all day working with various chronic pain patients, I mean, the burnout rate in this industry is extremely high. Which contributes to the scarcity, especially on the behavioral health side related to working with chronic pain patients. So giving providers a team of other providers to collaborate with, to bounce ideas off, to support each other has been one of their favorite parts of the program. And they often just remark how much they learn from talking to the other providers, things, maybe barriers to progress that they would have never seen themselves from their own training and experience.
Can you elaborate on that with respect to, you talked about patients going into the ER and then calling and needing a refill on the opioids, and how that relates to kind of workforce drain, and then also for the providers, freeing up some of these ER rooms by giving them the virtual resources, and how, what you've seen with the providers you're working with and how that helps.
Yeah. So let's take a typical patient who's not working with Override. If they are out of their medication, or perhaps there's nothing to do with medication, but they're just having a terrible flare up and decide that they need to be seen or treated, or they just need to consult with a medical provider right away. The option is call your doctor's office and see if maybe they can fit you in for an emergency appointment that day or the next day. The chances of that are pretty slim. Even getting a call back same day for most doctors, the chances are pretty slim, especially if it's already after hours. And at that point, the option is to suffer or to go to the ER. And many people may go to the ER and take up space there, and their health plan spends a lot of money on the patient that perhaps could have been avoided if that same patient was working with Override, was able to message their providers on our app and get a response from one of them, within a couple hours. And we're also pretty good with same week appointments as well. It may not be every provider can meet with the patient that same week, but one of the providers on the care team certainly can. And knowing that you have that support, that you have that resource built in, is often enough in and of itself to prevent someone from feeling like they have to run to the emergency room. And that's part of how we expect to reduce the cost of care, is by providing patients this lifeline and this resource that prevents them from having to take an extreme measure.
Carolyn?
Yeah, so it sounds like there are so many challenges in managing these patients. To you, what are the biggest challenges that these patients face in managing these chronic conditions over the long term?
I'm thinking about our Medicaid patients right now, and almost all of them come to us, not just with chronic pain, but they come to us with obesity, diabetes, hypertension, neuropathy, depression, PTSD. I mean, oftentimes there are 10 ICD-10 codes listed when we get the referral. And all of it is interconnected in a sense, right? That's another problem with traditional pain medicine, is the pain doctor may just zone in on the body part, right? May just say, okay, it's your knee that's bothering you, I'm going to inject your knee. And maybe they might say it would be good if you exercise, and losing weight will help take pressure off your knee. but they're not going to be holding the patient accountable. They're not designing an exercise and nutrition plan. They're not giving the patient the tools that they need to actually start making meaningful physical and behavioral health changes. But Override is pretty well equipped to handle a host of problems from all sides, the physical, the behavioral, the social. These are really hard patients. We take on the absolute hardest patients, and also some that are less hard, but some very hard ones. And we're better equipped to handle them than almost anywhere else.
So as you're managing these patients, I know a hard thing is to make sure that the patients are actually, committing to the treatment plans, following up on the treatment plans. What are Override's most effective strategies for improving that patient adherence to treatment plans?
That's a great question. We try to do it in a bunch of different ways. So not everybody is using the mobile app the same way. There are some patients who every day go on and they say, what is my agenda for today? Oh yes, I had a goal set this afternoon to do my home exercise program. I will check that off, and I will do my learning for the day on pain neuroscience education. So that is one engagement strategy, is to use the mobile app. The other is we encourage our providers to actively check in with their patients. It means a lot to a patient when between appointments, when let's just say your physical therapist is not forced to be spending time with you, decides to send you a message just because he was thinking about you. Hey, how is that new exercise going? So that's another engagement strategy. The biggest one is just that we're giving patients care throughout the month. It's very different if you're having a check-in with your doctor once a quarter versus knowing that you're going to be seeing your coach this week, and at the end of the week, you're seeing your physical therapist, and you know that they're talking to each other, and you don't want your coach to tell your physical therapist that you haven't been doing your home exercise program, so maybe you do it. We also have optional group coaching sessions once a week, and so that gives patients the component of peer support that a lot of them are missing from their home communities and families. And so that's another way that we encourage patients to stay the course and continue in the program. Basically, everything that we do is designed to keep the patient engaged in their own health outcomes and in Override.
Can you talk for a minute, Jennie, about, you mentioned the neuroscience education. I know you bought a coaching company. How important that is in this particular area, because it's a little different if you have, say a bulky knee, you can kind of put up with it. But if you're experiencing pain, and it's, I've had migraines, and it's really, really uncomfortable to the point of, having to go into a room with all the shades drawn and literally no noise. And your head is pounding, and I can only imagine and mine are not severe as many other people are suffering from this, how important it is to have that kind of giving them skills and tools so that they have something to go to if they can work with that, and how key is that to your program?
I think what you said makes a lot of sense. We are giving patients a toolbox of tools to help them when they're experiencing particularly difficult times, which could be every day for a lot of our patients. And those tools can be small things like diaphragmatic breathing or physiologic sighs, or humming, which is a tool to calm the nervous system. Or they could be much higher level things like reframing and working on ruminating. So it's really a range of everything from sleep and nutrition to managing anxiety and depression in the environment that you live in. But all of them are designed to help the patient to feel like they can start taking some control back themselves. When you're in pain, it's easy to feel like you're a victim. And like you don't have control over the pain. And to a certain extent, that is true. And but to a certain extent, especially if you can find tools that work for you, it can be comforting to feel like you have something in your toolbox to help.
Carolyn?
Yeah, I would love to know if you have any examples of like success stories or case studies where patients have felt like they have taken that control back in their life. It's like, is that common? Like, what are the outcomes like for you right now?
Well, about 80% of our patients say that they feel that their pain management abilities have improved after override. And specifically, I'm thinking about two patients. One of them who was traveling and was normally experienced a lot of difficulties and pain with traveling. And after working with Override, remarked that this was, a far less stressful and painful experience than before because of all that she's learned through Override. And then similarly, another patient had a surgery unrelated to the pain. But when you live in a state of chronic pain, any sort of injury or wound to the body can often be more painful and exacerbated for that person than for a person without chronic pain. And this patient, said that the surgery was a success, and it was all thanks to how she was able to cope with it and manage through it because of what she had learned with Override.
So Jennie, what would you, and maybe you can talk a little bit about your personal story, but what, would you like people to know about chronic pain? What would you like providers to know, maybe even first level clinicians, that would help them in treating this or in recognizing this, that as someone who suffers from it, that would be helpful to them?
So it sounds like the first part was, what do I want people generally to know and understand? And I think that is that there is no cure-all for a lot of chronic pain. And, of course, I feel strongly about Override and its ability to help people. But I also try to be pretty clear that we are not a program that promises 100% relief or even any relief necessarily. I mean, what we are aiming to do is to help people to cope better, to lower their pain experience, and to have a better quality of life and physical function. For the most part, that's the top level goal. And for some people, chronic pain is curable and they just haven't had the right care yet. And for others, it may be a lifelong experience. But that doesn't mean that these patients should be disregarded and thrown away as unhelpable or as difficult or as too frustrating. So I guess tying into your question, what would I want providers to know? I think I'd want them to understand that chronic pain is an entirely different beast than other conditions and acute pain. And if they don't have chronic pain training, which most providers do not, there's no shame in that, and there's no shame in asking for help. There is no shame in, taking a patient of a primary care doctor or something and saying, I don't feel like I'm giving you the resources and the help that you need. And I know of a program that can help you, or it doesn't have to be us. I know of, something else that can help you. So I think, the more that the healthcare system in general can learn to work as a team and an integrated care approach and lean on each other, especially for the more complicated patients, the better.
It's very helpful. Carolyn?
Yeah, I would love to know. Can you share any like future plans or upcoming initiatives for Override Health? Like what's next on the horizon for you all?
For the most part, we're focused on growth. We've created a fairly smooth and operational clinical model that is working well, and we have the clinical outcomes to back this up. And now we really need to expand the number of patients that we're helping and show growth in order to in the next year raise another financing round.
So I have just one last question, and then I'll turn it over to Carolyn, see if she's anything before we close up. So Jennie, part of this is called Diagnosing Healthtech, and I know we've had a couple of brief conversations about starting a health tech and growing, and you've seen a couple of different environments, one an extremely hot funding environment and then a much tougher funding environment. So any advice for other startups out there? You've raised, I think, in both environments, recently raised a little bit in August. Any advice for CEOs or health techs out there?
When the environment is tough, it's all the more important to have a really strong business plan and to have really thought it through that the business model will be successful. There is a much higher bar. And the other piece of advice, maybe I would say, is not to take it super personally. Maybe the investors are under a lot of pressure from their limited partners, their investors, to produce results. And the tough environment is tough on all of us. It's tough on them. It's tough on founders and CEOs, and it's a hard environment. But so many of us are doing work that is helping to change people's lives, and that if it wasn't for our specific companies, there would be a gap in the market and in the world. And so it's important to stick with it if you feel like it's going to really help people.
That's great. Carolyn, any last questions before we thank Jennie for her time?
I'll do my favorite wrap-up question. Thank you so much for joining us, Jennie. What do you see as the future of chronic care management? What advancements do you anticipate in the coming years, like 3 to 5 year vision?
Well, Medicare has already started recognizing value in collaborative care, and likely the commercial plans will follow. So I think that there will be a return, or a slow return, to collaborative care, which may end up being very helpful, but the implementation is going to be absolutely key. It's not easy to make change anywhere, especially in healthcare. So we will have to just stay tuned.
Well, thank you very much for your time, Jennie. We really appreciate it. And we wish you the best of luck going forward. This is a really crucial area for a number of groups, wish you all the best.
Thank you so much. Thank you for having me on, Jeff and Carolyn.
Oh, our pleasure.
Thanks, Jennie.
So with that, we are going to wrap it up today. So as I said, I'm Jeff Englander. I'm the founder and principal of the Healthcare Strategy Bullpen. We help providers and payers adapt and deploy healthcare tech to improve the lives of patients. We help innovators to be more effective in deploying their technology within the healthcare ecosystem. We work in 4 areas: operationalizing data to maximize its analytical value, demonstrating the benefits of new applications enabled by digital health, applying digital health to high cost and chronic conditions, engaging and managing the practical, cultural, and technological issues around social determinants of health. Please check out our RPM Market Landscape Report, which is available on our website, healthcarebullpen.com. Please follow us on LinkedIn and on Twitter at HealthcarePen. The report is on our website, once again, healthcarebullpen.com, under the podcast and webcast tab. Our guest on May 2nd will be Michael Sankey from Databricks. Apologize. And with that, I will turn it over to Carolyn to close us out.
All right. Our show is also sponsored by Redox. We are the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. Be sure to subscribe to Diagnosing Healthtech on any podcast platform, or you can scan the QR code up here to get updates from all of us at Diagnosing Healthtech. Thank you for watching, and we'll see you next time.